teenagers, there is an increased incidence of cancer. Things that they can't really deal with, infection as well. Um, they have a lot more difficulty resisting diseases, and they've been around so many carcinogens all their life um, that that's why we see cancer. And of course, as cells die, we have lots of cancer cells in our bodies. They're called free radicals, basically, and we know that a lot of those free radicals are in there from the very beginning of life until now. And so that's why we see cancer as one of the second leading causes of death. Cardiac is the first, of course. When we're looking at the challenges, we know that our older patients also have a high risk of atherosclerosis, and they also have hypertension. So whenever we give them some type of cancer medication, such for instance tamoxifen, it actually increases the risk of stroke. That's why they don't do as well when we are giving them tamoxifen, because of the age-related changes. If they have to go to surgery for cancer, we know that the medications that they give them, and even pain medications, there's an increased risk of delirium because of the side effects and adverse effects. Remember, the metabolism is much slower to get rid of those drugs in the body. There's a decrease in lean muscle mass. So it's harder for them to get their range of motion in. They're not as physically strong. And so they need a lot more physical therapy than maybe a younger person would need. The longer it takes for an older person to recover really can increase the risk of immobility. And I like to say that the presentation we had this morning with the example of the 81 or 85-year-old woman after her surgery, she is definitely an example of someone who has increased resilience, as I mentioned earlier. And so it didn't take her very long. She's only gone 5 weeks, and she looks like she's doing really well. And I believe Steve mentioned that she was going to be discharged soon. So that's not so the norm. So we do like to see that. We also know that a patient that has cancers, and some of the challenges is the ability to develop malnourishment or malnutrition. They can develop dehydration quickly. Of course, constipation is always an issue. Infection related to hospitalization and even the surgery is also a difficult thing for cancer patients as the older adult. Remember, the skin breaks down because of multiple reasons, but remember there's very little subcutaneous fat. Sometimes the drug interactions can cause skin issues and organ issues as well. And there are more complications from the comorbidities because of the rate of chronic illness. So you have a patient that has multiple comorbidities. And then, of course, the combination of all of that and having cancer at the same time and being treated for cancer, really, we do see a lot of high mortality rates in that. There are risk factors, of course, over time. Tobacco products is a given. Exposure to the sun, of course, over a lifetime can increase not only skin cancer, but other types of cancer. A diet, we need to keep, really the diet is something that we follow the entire lifespan. So if a person starts off with less red meats and make sure they eat plenty of fruits and vegetables and stays away from a lot of fats and fried foods, their risk is a little bit lower. The pickled food and the smoked meats that we totally eat all the time, or even the cured foods, gives us an increased risk of developing cancer, colon cancer, and other types of cancer. All right. And of course, we do recommend that they have an acceptable weight and do some exercise, even as an older person. But again, a lot of these risk factors can be minimized if we teach younger patients how to take care of themselves throughout their lifetime. Some other risk factors that we really are concerned about is carcinogens, and it could be asbestos, fertilizers. There's something called nitrates in fertilizer, maybe y'all heard a couple of years ago, in fact, I still see it, where those patients are getting cancers from Roundup, which is a weed killer. It was used for, I mean, Lowe's was selling it, and I used it all the time in my place up there in North Florida. I'd be out there spraying the weeds and stuff with this Roundup. But luckily, I haven't had any issues with it. But there are people who are developing cancers from that, whatever's in the Roundup, some type of carcinogen. And of course, the more alcohol a patient drinks over their lifetime, the increased risk of liver failure, liver cancers, esophageal cancers we see, smoking, as I mentioned earlier. I worked on a head and neck cancer center at the VA up in South Carolina some years ago, and majority of those patients had head and neck cancers. And the reason they had so much is that they were heavy smokers and heavy drinkers. And of course, they had not had a lot of health care. They were old veterans, so they didn't really go to the doctor or have a lot of health care. And so they wound up on the oncology unit that I worked on. And I'm telling you, it's amazing to see how cancer can affect the head and neck and the esophagus, developing all kinds of esophageal lesions, and just simply from alcohol and smoking. So we need to teach our younger patients to try to refrain from smoking and over drinking. Okay. There really is no current evidence that food allergies, or additives, I should say, or coffee, or even the fluorination that's in our waters, and stress increases the cancer rates, but we do know that some of these things can affect us overall in other areas of our body, maybe cardiac, but for cancer, it's really no evidence as of the last edition of your textbook. Okay. And of course, family history is always something we want to look at. That's why we like to do not necessarily a genogram, but look at a patient's 3 generations of family members and kind of see, did the great grandfather die of cancer? Maybe the grandfather had lung cancer, and maybe their father had lung cancer. So we look at all of those factors from the genogram, and so by doing that, we can actually do a lot of patient teaching and health promotion just by looking at the history and the physical problems, medical problems that the family members have. Sometimes the patient may be perfectly healthy, but they live in an environment in which everybody drinks heavily, alcohol, maybe moonshine, right? And so those will also increase the risk for cancers. And as they get older and they're still drinking, then of course there's always a potential for developing the cancer. The highest rates of, say, skin cancer is in Australia and Hawaii. I mean, it makes sense. Everybody's outside in the sun, and it's very hot in those subtropical areas. So wearing hats and long sleeves and lots of sunscreen and limiting the amount of time that people stay outside in the direct sunlight, of course, can help reduce some of that skin cancer. Papua New Guinea and the Philippines has high incidences of mouth cancer or oral cancer because of tobacco use, the chewing of the betel nuts, right? They will have those. They do a lot of the chewing of those nuts. And so we kind of recommend that decrease of smoking cessation. That's why we do it at a younger age, or at any age, really. I've had taken care of a lot of patients who've had lung cancer. I had this old gentleman one time that he had stage 4 oat cell, small oat cell, which is a virulent form of lung cancer. And he was so emaciated, but he was ambulatory and, talky. He had no mental problems. He was an older gentleman, but his breath smelled so fetid. It smelled almost like feces because his lungs were so rotted. And he was still breathing, still walking around in the hospital. Of course, he was there for a lot of treatment. And so he definitely had that cancer, and he had left it untreated because he didn't know he had cancer. Because remember, cancer of the lungs, initially you don't even realize you have problems until by the time they find it, the lesion can be quite large or even have metastasized. But tobacco use and the chewing of those betel nuts can also cause mouth cancer. A lot of mouth cancer on smokers. Esophageal cancers as well. Colon and lung cancer is pretty high in West Virginia due to the radon exposure. You know, radon is a naturally occurring element in the soil, and there's a lot of that up in that area. And so they do have high rates of smoking in that area, and their diet is also a problem. So that's why we do see West Virginia having a high incident rate of those types of cancers. Now there are places that are looking to do radon tests to make sure it's nothing in the ground, because it comes up from the ground and you don't really know it's there. Talking to our patients about colonoscopies and screenings for that would be something that we might want to do. And of course, if there are any polyps that are discovered within the intestinal tract, that would help reduce the risk of cancer. So let's talk about recommended screenings for our patients. Excuse me. Of course, annual checkups and the annual mammogram, as we've mentioned. The fecal occult blood you're familiar with is also something that could be done annually. A colonoscopy is about every 10 years. For women, the Pap test is about every 2 to 3 years, and it's less for over 70 years, as we mentioned earlier. And of course, a PSA every year for men and a digital rectal exam for men because they're looking for that prostate swelling. So there's some recommended screenings. Some of the complementary treatments that is recommended for patients who have bladder cancer or even diabetes. Vitamin E is really, really good to help cancer. It also helps to improve insulin resistance. Sometimes insulin therapy for cancer might be contraindicated with diabetes. Garlic and ginseng is also contraindicated for cancer because remember, they can cause hypoglycemia. But there are some things, so we know that vitamin E is really good. For lung cancer and COPD, white tea extract might help with some lung cancer. And now your book actually mentions about smoking marijuana to help reduce nausea from chemotherapy. And we know that in many states now, marijuana has been legalized to a certain extent. And so lots of patients might use that for chemotherapy for that nausea. For colon cancer, as well as depression, multivitamins such as St. John's wort can help with some of that colon cancer. All right, but remember, St. John's wort is used for memory, for mental clearness, and it also has some side effects as well. So we have to look at all the side effects of these. Melanoma, which remember is a pretty virulent form of skin cancer, and we talked about that this week in under skin presentation. Antioxidants are very helpful, such as vitamin C. We would not want to use things like ginger or ginkgo for that, or garlic, because it would probably affect the aspirin use. All right. But we have to be careful of massaging. So there's many, because of, especially in the areas of cancer, because we don't want to seed any of that cancer. So again, there's lots of different types of complementary therapies they can do with someone who has cancer or has actually the risk for cancer. So we can actually teach a lot about health promotion for patients who have a history of cancer in the family. We are very familiar with the acronym for caution about cancer. Of course, it's a change in bowel or bladder habits. Is the C. I forgot to bold the C, sorry. All right, a sore that doesn't heal, of course, an unusual bleeding or drainage, thickening or a lump in the breast, okay, or anywhere else for that matter, having trouble swallowing or indigestion, changes in warts or moles, and of course a persistent cough or hoarseness. These all have to be kind of diagnosed and assessed by the healthcare provider to make sure there's no cancer involved with that. Patients, older patients as well, who have some concerns about cancer, especially if they have a diagnosis of cancer. Remember when you study cancer, they have a lot of fear. They're afraid of losing a breast, such as a deformity. Many of them feel that they have a loss of independence, which is something that we need to help them with, because we want them to be as independent as possible, but they have these fears. They've heard myths about cancer. They don't have enough knowledge about the treatment options, and of course they're thinking about death. And so what we need to do is really to assist them to care for themselves as much as possible, talking with them how the side effects of the treatment are going to be managed. If they need transportation to and from the chemotherapy clinic, of course, we have social workers and case managers that help us with that, and providing social or emotional support. All of these things that we're talking about really can be used for all age groups. But your textbook does a good job of bringing this information out. And for our older patients, cancer, unfortunately, is way up there on the risk for developing cancer as they get older. Sometimes people who get cancer, sometimes they don't, they just kind of go within themselves. They lose interest in life and people. They don't pay any attention. They don't want to talk about anything. And so sometimes that if we do like that little genealogy diagram, not the diagram so much, but just the questions about their family members, we really can encourage them, and particularly in preventing future cancers, things that can be prevented, like smoking and weight and that kind of thing. So, and also the importance of screening for cancers. All right. So be sure you know the caution, what it stands for. It's important. All right, so let's kind of look at a couple of questions here. An older client will ask, so many television commercials focus on actions to prevent cancer. And so what should the nurse say to this client? What do you think? Which would be the best answer?
C.
Yes, it's going to be C, obviously. Yes, well done. Because truly, there are a lot of commercials on TV. It does tend to cause people to be frightened, but that's not the sole purpose of that. What we've discovered with these commercials, and I think the companies know that. So when a person is sitting there watching TV and they see this commercial about this new drug that's come out, the first thing they're going to do is, in general, they're going to talk to their healthcare provider, see if they can get that drug. So it's really a form of marketing. But again, if there are ways that we can help reduce the risk of developing cancers, then it's good to have those commercials to kind of remind people about the importance of it. And of course, here's the word caution for all the warning signs. Which one of these is not acceptable as part of this word caution?
E.
Which E? Did I hear E? Yeah. Just a sort of kind of reminder. So all of these, and E is the one that's not necessarily a warning of cancer. All right. So here you're teaching a 73-year-old client about a new cancer diagnosis. And so what is the priority nursing intervention associated with the client's understanding of their diagnosis?
D.
I hear D. Absolutely, it's D. Okay. So really, we do want to know what the client's thinking about the treatment plan. And we also do that, not only their feelings about it, but do they understand what the treatments are going to be? And I think that's important to remember. We are probably going to talk about how to manage nausea and vomiting if that particular therapy is going to cause that. Of course, of community resources, we can talk about that as well. All right. And even complementary therapies, the doctor may have already mentioned some of those, and we can always reiterate those therapies so the patient knows that there is many ways to deal with a cancer diagnosis. All right. This is a very short chapter, so that is it. Just a quick review of what you have learned before. Any questions about this? All right. So what we're going to do is we're going to go into acute care, which is the last one that we are doing today, and the one that you're most likely more familiar with, because acute care is something that you've been doing since the beginning of nursing school. You've been in all kinds of acute care settings and hospitals. So let's talk about what is that acute care. When we talk about the older population, we know that an older person, they tend to have higher rates of staying. Their lengths of stays, the LOS, which is an acronym we use, LOS abbreviation, really means that these older people tend to stay longer in the hospital. They have people who have older adults, they tend to be hospitalized before a younger person because of all the changes in their bodies and things like that. They use a lot of outpatient hospital services, of course. Remember, don't forget all those age-related changes that we talked about, the cardiovascular, the respiratory system. Those are all important to kind of remember. And we know that our older population is at increased risk for injuries and infections and complications. Y'all have something to look forward to, huh? Yeah. So we do know aging is part of life, and this is how we have to deal with it. All right. And of course, older adults do have unique needs when they are in the hospital. Let's talk about what are those unique needs if someone is older, because not every person you're going to take care of needs to be the same, will have the same needs, but older people have a lot of unique needs. And here, the first one here is dosing of medications. Remember, with medications, we want to, the doctor will try as much as possible to start with a low dose, go slow, don't change things too quickly, let them adjust to that. We do know that there's lots of sensory deficits with our older population: vision, taste, hearing, touching, feeling, those things. Sometimes we have to address each one of those and provide nursing interventions that deal with each of those sensory deficits. Of course, if they have arthritis or osteoarthritis or some other form, they might be weak as well in their joints and their muscles. Well, then that's going to be a problem. Sometimes they have difficulty with the call lights, the use of the TV remote, light switches. We have to take that into consideration when we admit an older person into the hospital. We've talked so much about their skin. They have very fragile skin. It tears easily. Particularly the shearing forces of them sitting up in bed becomes a problem. If they are incontinent or have any other type of bladder problem, then we know that we have to be very meticulous with that skin care. We should do that anyway, but even more so with those problems. We have to protect them from becoming infected on those skin tears. So that's why we really, as nurses, we need to be doing a skin assessment on our older patients every day. At least once a shift when you're working on that shift, to be sure you do a really thorough skin assessment. If you know that you're not going to be the one bathing that patient, find out from the CNA when they're bathing the patient or whoever is doing that. And so you can come in and actually look at the back and actually look at the buttocks, because that's where a lot of the skin problems are missed. They're on the back or on the buttocks, on the sacral area. Of course, constantly telling them about repositioning or actually repositioning patients, of course, is something that we have to continue to do. Coughing, turning, deep breathing, toileting. All these things are very unique for our older population. And of course, mental status. As you know, hospitalization can cause confusion and actually can cause delirium in the hospital from the medications, from just being hospitalized, from the anxiety that they may experience. So they can develop delirium. And so any subtle changes in their mental status must be observed by the RN and acted upon. So pay very special attention to any subtle changes. Your observation skills, as you've heard me say many, many times, is so important to the care of your patients. So you will develop those skills as you grow in nursing. All right. So lots of unique needs. There are many risks associated with being in the hospital. We've talked about a lot of this kind of things throughout this quarter, but obviously we know that their functional status may decrease. Maybe they've had surgery. They may not be able to ambulate as much as they could or they should. Maybe they're having difficulty bathing themselves. Any type of functional ability could decrease. Their respiratory system needs a lot of extra work in the hospital. So we need to be watching for that. Nosocomial infections. Oh, please be sure we are washing our hands, maintaining a clean environment in their rooms, healthy nutrition. All of those things are important. And of course, the iatrogenic complications. Unfortunately, we do see these here. Delirium, I've mentioned. Falls. Oh, our older patients class is at risk for falls in the hospital. We need to be sure that we have assessed for this fall risk using the Morse fall risk that you have learned, or whatever tool your hospital uses is fine, but the Morse one is very common. Looking at pressure injuries. Checking for their dehydration or their hydration status can be a terrible complication of being in the hospital. Of course, incontinence. You may have a patient that was not incontinent when they came into the hospital, but because of all the trauma, maybe a potential for delirium, some of those things, it could be that they develop some incontinence. So we have to address that as well. All right, constipation is always something to think about as well. And of course, think about their mental status, because they're losing some independence. We want to keep them as independent as possible, but we know that there could be some a lot of patients who are going to need your help to move, to ambulate, to brush their teeth, to wash their back, those types of things. So lots of complications associated with hospitalization of older adults. We must remember that, making sure their linen's clean. I could just talk for an hour on that, but I think you get the point. How many risks are we associating with our older adults particularly? So a true or false statement: many older adults who have lived independently in the homes prior to hospitalization are not discharged with the same level of function and may require nursing home transfer. What do you think? Is this true or false?
True.
Absolutely. You are so correct. Yes. And that's what's kind of scary for nurses. We have a patient coming in. They came in, say, with a stroke, maybe right-sided weakness, that kind of thing. And they were independent at home until this occurred. And then now their functional status has declined. Maybe their mental status has declined a little bit. And so now they wind up going to nursing facilities or to a rehab center. So yes, it is true that many of them wind up doing that, going to rehab. And we don't like to see that, but it is not uncommon for that to occur. Okay, all right. Not uncommon. So ways to minimize the risk, of course, lots of things. Assessing, 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 and assessing. You never stop assessing your patients. And of course, you're evaluating as well. But assessment is an ongoing process. It must be every time you walk in that room, you are assessing your patient. You may not realize it, but you're looking around the room. You're looking at your patient. You're looking at them breathing. You look at the skin color. You look at the smile. If they give you a smile or they don't give you a smile. So all of those things can help registered nurses identify early subtle changes that are going on with our patient. The slightest changes in vital signs must be taken seriously. Maybe everything is okay, maybe it's not okay. We put in so many IVs on our patients, our older patients, and again, all the issues with infection, overload, circulatory overload is another issue. So really do assess your patients. And as you are assessing your patients, you will be able to identify problems. You are developing care plans, and you've been doing that since you came in the nursing school, but you're going to notice you're not be writing no big care plan when you go into transition. You don't have a care plan. You're planning care. You have to plan your care, but it's differently. You're developing the ability to plan care and internalizing that process, because now you know about that care planning process and you will do it internally. So it's important to keep in mind that you're going to be doing the same thing when you're in transition, and once you graduate and become a nurse, you're still going to do the same thing, but it's going to be in a different way. Of course, we always want family and friends as much as possible, because to help the family, to help the patient who's older. But with the COVID, it's getting a little better now. I heard some good news this morning, and for Florida, there's less COVID cases now and fewer deaths. So we're seeing a nice trend. But for a long time, for over a year now, our older patients could not even have family members in the room. We call that isolation, and that is not healthy for our patients. All right, so again, we just want to make sure if as soon as possible, families and friends can come visit, and hopefully they have some. Don't forget all that psychological effects of isolation. We talked about way back in Essentials of Nursing. What can we do? Maybe if there is some volunteers that work in your hospital, maybe they'll come around and talk with the patient. But again, comforting and helping them to keep functioning is an important piece. We always do discharge. Remember, discharge planning begins on the day of admission. Case managers, that's a massive role, and I imagine you have met some case managers at your hospital that you've been working at. But early discharge planning, we've got to plan ahead. And so we definitely use a case manager to help us with that. We use social workers. So you will learn how to work with these healthcare team members in planning discharges for your older patients. Independence, try to keep that encouragement, make sure they have as many assistive devices that they need, whether it's a bedside commode, whether they need, maybe you feel like they might need some type of ambulatory aid. Of course, that's why we have physical therapists. They can come up and evaluate, and they can provide canes and walkers, all kinds of things for our patients. Occupational therapists are really good to help with those minor movements, such as feeding themselves. So independence as much as possible. Medications is always at the top, obviously. It's not at the top of my slide here, but you know how important medications is. And you will see that come into play when you get into transition. You're going to walk in there with another RN, and you're going to be taking care of patients just as if you were an RN. And so you're going to start seeing all of this stuff is so important to the care of your patients. Of course, we always try to anticipate what could possibly happen. of complications. So we want to try to anticipate, if the patient has become maybe incontinent, we got to think about, oh, that could be a problem with the skin. So please be sure you are doing everything you can to prevent complications. If you have an older patient, I've seen this a lot, let me tell you, who comes into the hospital and they're laying in the bed for 3 or 4 days. Their heels are at the bed, right? Their heels are on top of the bed. You can lift it up when you do your heel assessment. Remember, don't forget that heel assessment. And they're turning red. There are things that we can use in the hospital to help try to decrease the potential for these older patients developing heel injuries or pressure injuries. All kinds of boots, lamb's wool, I mean, you name it, they're available. So please think about complications. If you have an IV running on your patient, again, be sure you're doing really good respiratory assessments on that patient and cardiac assessments because of the potential for fluid problems. All right, lots of things. Environmental safety, of course, is that the room, making sure the room is clean. All of those basic skills that you have incorporated into your practice since you came into nursing school. Do those safety protections. Watch those side rails. Make sure the bed is down. If I cannot stress anything else, class, please, if you move away from that bed after you've done some kind of procedure or assessment, do not leave the bed up for a split second. It's all it takes for a patient to just, especially older patients, they might think, oh, I need to get to my chair, and you may have your back turned to the computer because we're always thinking about the meds. You got a patient back there, and don't leave the bed up. That's how many patients fall. I've seen it happen tons of times in my career of nursing. Make it part of what you do, all right? Part of what you do. Always checking for the bed positioning, the hand washing, those things, all right? Okay, as far as education, of course, we do know that for our older patients, based on their mental status, remember these learning domains, the cognitive, the psychosocial, the psychomotor, the affective domain. Remember, affective domain is those things that the judgments and the perceptions of the patient. Be sure that when you are teaching them, that you're teaching in the correct domain of learning and making sure that your environment is conducive for their learning. In other words, like very few distractions, making sure the patient, especially the older patient, is not tired after lunch. You have to choose the right time to do a lot of teaching, but we only teach but short periods of time, say 10 minutes at a time, because they cannot handle any more than that. I always remember too that if your patients are in pain, take care of that pain before you even try to teach them, all right? Because you're not going to remember anything you said if they're hurting. So keep pain at the front of your mind as well. Do that good pain assessment that you've learned how to do in class. All right. Okay, for surgical care, we did do a lot of studying of surgical patient perioperative way back in Essentials, but I'm sure you have run across a lot of this in your practice already. But do know that there's lots of complications that can occur for an older patient. They can become hypothermic very easily. Their overall body changes can be a problem for surgical, so keep those things in mind. And we want to make sure that they are, again, as independent as possible. But we want to make sure that they're safe going into surgery, checking those lab values and all of those things, right? After a surgical procedure, as you well remember, I'm sure, that many times patients can become confused. Those older patients, they could come on your unit, say you're on a med-surg unit and you have an older patient that's going to come back to your unit and they're confused, or maybe their personality has changed a little bit. If they had just had surgery, that anesthesia or whatever, the drugs are still in that body, and so it can cause alterations in their mentation. Even though they're fully awake, alert, and oriented, keep in mind that because of their age-related changes, they can actually can be damaged and injured if they have gone to some type of delirium or changes in mentation. It's not uncommon for an older person to come back from surgery and the family member will go, "Oh, my mom just ain't acting right." Okay, because we do see that decline. It's usually self-limiting though, so but again, watch for that. Again, some more age-related changes, of course, here. Just remember that older adults are less able to compensate to the cold, to the increased amount of drugs. You know, their liver doesn't function as well as it should. Their creatinine clearance time is diminished. Their kidneys may not function as well. So they are really prone for hemorrhaging, for infection, as we've mentioned, anemia. Their blood pressure can change. It can fluctuate. It can drop quickly. Again, watching for that. And we've mentioned multiple times about fluid and electrolyte imbalances. So be sure to watch those lab results. And they're very problematic. Because of the age-related changes related to the vessels, remember the vessels are not as elastic as they should be, all right? Possibly they had some malnourishment, or maybe they are NPO for a while, or they're not being able to eat certain foods. They can have some malnourishment problems, and so we need those nutrients. Don't forget protein and zinc. We got to check the albumin, preferably the pre-albumin is the best one to check. Look at the H&H. Look at the liver function enzymes, the ALT and the AST. Look at all those things, and of course the electrolytes. Okay. They also have reduced cardiac reserves, so those types of things can really interfere once they've had surgery, or just being in the hospital can be a problem. All those age-related changes. And remember, renal is not functioning as well as it would have been in an earlier time frame. Okay, so keep all of those things that you've learned. On page 476 in your textbook, there's really a really good table, causes or contributing factors for the older adults. I've mentioned quite a few, but just take a glance at that table. It'll help you, remind you of some of those changes and problems. Again, for preoperative considerations, you want to think about reactions to anesthesia. You've got to know what kind of anesthesia they're going to have, and obviously what kind they had after they have returned from surgery. You need to know the length of the surgery. What does it mean? What is the description of the surgery? What's really going to happen to the patient? You're going to have to actually teach your patient some of these things as well. Once the informed consent is signed by the healthcare provider, and then we can follow up with that as well with our patients. Explain to your patients about the recovery room procedures, where they're going to go. Sometimes you do know that the patient might come back to, say, your med-surg unit, but then sometimes they're going to say, no, she's going to be discharged home, depending on, what kind of surgery. So you need to be sure you're aware of that so you can teach your patient. Always talk about pain, because that's a big issue. Don't forget pain, fifth vital sign. Okay, and you want to explain to your patient how you're going to manage their pain after surgery. Teach them all those nice teaching, coughing, deep breathing, exercises, turning, why it's so important to turn. It expands the lungs and helps them to become oxygenated better. All the things, IV sticking in a patient, and maybe they have to have a catheter put in. We have to explain to many of our patients the purpose of these things. So when you're preparing them for surgery, or even if they're not in surgery, be sure you're doing a lot of patient teaching. It's important for them. If they're going to come back for dressing change, for dressings, they have dressings. If they're going to have to be suctioned, if they're going to be on oxygen, all of these things have to be discussed with your patient. Again, not all at one time, but as much as you possibly can. Teaching is a huge piece of our business. All right. Of course, there is a pre-op screening that we generally do for our patients, EKGs, x-rays. Sometimes they'll have a pulmonary function test prior to surgery. Not always, but if they already have a smoking problem, they've got some pulmonary issues. If they're really obese, sometimes the surgeon might order a pulmonary function test, because remember, their reserves are not going to be a lot big. Remember, as far as age-related changes, there's fewer reserves. You have less elasticity of the alveoli. Your muscles don't work as well. They're using a lot of accessory muscles, which makes it a little bit more difficult to breathe. Their vital capacity drops. They can't really take nice deep breaths as much as they should. So respiratory-wise, they are at high risk when they go into surgery. And don't forget your nutritional assessment as well. We're going to be sure we do that. You know, the height, weight, diet history, all of those things. And of course, if they're going to be on a special diet after surgery, we need to teach them a little bit about that as well. And be sure you're looking at their mental status, because a good baseline prior to going to surgery or prior to a procedure, if you as a nurse has a really good idea of what's going on with this patient, you know their baseline, and then they come back from surgery or from the procedure and you see subtle changes, do not ignore them. Do not ignore them. Okay, important. Okay. All right, so which of these herbs influence blood clotting and must be documented in a medical record prior to surgical procedures? Actually, there's two here. It's not really, it's going to be a select all that apply, but I only put 4 answers. So which 2 of these do you think might need to be documented because of it influences blood clotting? Oh, I did. Yeah, ginkgo biloba, that's what you said. Oh, I just realized I left off the ginseng, but ginseng is also one that will affect blood clotting. So you might want to write that down. So actually the answer here was correct. It was ginkgo. Can mess up the blood clotting. Again, we've talked a whole lot of information about the aftercare. Oh, sorry. However, don't forget your positioning. During surgery, as you recall, patients are on these really small tables. They're hard. They might be in strange positions depending on what's going to happen in surgery. So they're going to have some post-operative muscle soreness, perhaps. Maybe some bones might be hurting a little bit. Expect that. And there's some things that we can do to help them with that. They really don't like to do long surgeries if they can help it, simply because of the ages of the patient. Hypothermia, I've mentioned already. All right. A few other things on here I've mentioned many times about vital signs. Checking for shock and hemorrhaging. What is the earliest stage of shock, class? Let me hear it. What's the earliest thing that you might see in someone going into a hemorrhaging and a shock? The very first thing you're going to see.
Low BP, increased heart rate.
Okay, that's some things that could occur. But what's going to be the first sign that there's something wrong with this patient?
Is it a change in LOC?
Yes, they're gonna be a little bit like something's not right. For your hemorrhaging, if somebody is going to hemorrhage, remember we talked a lot about that. For hemorrhaging, you'll initially see they become restless, because remember the pulse, the oxygen is not getting to the brain like it should, so they'll become a little bit restless. Hypoxia will develop. If you're seeing your patient and you kind of didn't see all these early signs, and sometimes it's subtle, and then all of a sudden they're cyanotic, we miss something. That cyanosis is going to be one of the later signs of hemorrhaging and shock. Okay, so keep an eye on that. Of course, your urinary output, we like our patients to be able to void within 6 hours. So just keep a watch on that. and then do your checks. You can do your physical assessment for bladder distension, making sure they're not having any trouble with the urine. Fluid electrolyte balances, of course, you're going to be monitoring all of those as well. All right. Don't forget, intake and output is very important during this time. Malnutrition can occur for our patients if they don't eat well. So be sure we're getting in intake and output. Take care of that. And of course, if they have, depending on other kinds of things, for instance, that they have an NG tube or they're coming back with a colostomy, all those things are important. But what I'm kind of referring here to is the patient themselves, not all their gadgets that are attached to them. You still do that. But remember, it's your patient you pay attention to first, not the machines, right, or the equipment. So take care of your patient first. And of course, we talk a lot about pain. All right. Okay, there are some more here. I think we've probably talked these a lot, but just be sure you're looking at common complicating conditions in older surgical patients. It's on page 479 there for you. We've talked about almost the majority of all those, but there might be some in there that I did not mention. Okay, we don't want them to get all tight, so we just got to make sure they move as soon as possible. And if they can get up as soon as possible, that's what we want to see. Get them moving. Okay, older adults may demonstrate restlessness as the primary symptom of hypoxia after surgery. We've already answered this. It is absolutely true. It could be that they are developing hypoxia and not pain. Remember, pain can cause restlessness as well. So be sure you're checking that pulse ox, and those types of things, respiratory symptoms. Also, if they're on narcotics, that it's a respiratory depressant. So you want to make sure you're paying close attention to their respiratory system, all right? Anything below 10, we get really worried. If a patient is not breathing, you can always stimulate them to have them breathe, or talk to them, all of those things. We want them to deep breathe as much as possible. Observation is critical, and that's what the RN does. We do a lot of tasks, I know, but our observation skills on our patients, that's important. And you're going to start putting these into practice in just a few weeks. You're actually going to be out there with these patients. So use those observation skills that you have begun to develop in nursing school. And of course, don't forget, some patients do get confused and maybe have some delirium after surgery. So watch for that. There are some emergencies that we have to think about. And on page 481, I don't think I wrote it on here. No, on page 481, there's a selected emergencies for older adults, clinical manifestations and some nursing actions. This is a really good table to help you deal with any types of emergencies that might come up. Many reasons why it's better to act on something than not act on something. In other words, err on the side of safety. Always think about safety with those patients, right? We've talked about confusion, that's an emergency. Dehydration, falls is an emergency. And myocardial infarctions, patients going to have heart attacks after surgery, all right? So things to look at. We've talked a lot about infections. However, don't forget that the altered immune system in the older adult will change their ability to fight off infection, their decreased respiratory system. Remember, they have a reduced ability to cough. Remember, the bronchioles are widened. Okay, don't forget that. They get bigger, they become more dilated. Their bladder muscles do become weaker, so they can have some urinary retention. Some of the men might develop some hypertrophy, and so that's an issue with their urination in the hospital. And of course, vaginal secretions can also be more alkaline. So all of these age-related changes can cause infections and problems with our patients in the hospital. And mucous membranes, skin, those things. They're also many infections and related to, of course, chronic diseases. Okay. And the thing is, because they are in the hospital, they have a higher risk of getting a urinary catheter. They're going to have invasive procedures, maybe a heart catheter or some other type of invasive procedure. IVs, that's one that's invasive. So all of these things can cause problems, and watch for their immobility, because even immobility can cause an increased risk of infection. They can't deep breathe if they're just laying there in the bed. So we do want to prevent infections as much as we can. Hydration, nutrition, vital signs, flu vaccines, and hopefully they would have had a pneumonia or flu vaccine. That's one of the reasons we check on that when they first come into the hospital, our older patients. And sometimes it's offered to the patient if they have not had those vaccines. Okay. For infections, there's some herbs that are kind of good to use at times. Of course, echinacea, you're very familiar with that one. And golden seal is also an herb that is good for infections. And vitamin C and A. Watch for infections. We don't want a patient have to have an increased length of stay in the hospital because of some type of infection, whether it's from the insertion of a catheter or an IV line or a wound infection. So really watch those. If they have wounds or surgical wounds, be sure you're paying attention to the infection that could be potentially showing up in those wounds. So watch for that. All right, so gerontological nurses should suspect an infection when there is any abrupt, unexplained change in physical or mental function in the older adult. This is absolutely true. Sepsis is a big cause of problems, and that's why many of our older patients are admitted to the acute care center, to the hospitals, simply because they have developed sepsis. Many times that sepsis is caused by urinary tract infection or pneumonia, which has now become bacteria. Of course, it's bacterial, and so it's going to get into the bloodstream. It's going to cause all kinds of major issues, high fevers, lactic acid changes. So be sure you're watching for any suspicion of an infection with your patients. Well, we got to discharge these older patients, right? They're going to get discharged based on themselves, but once they are ready to be discharged, we need to talk with them about their perception of how they're doing, their prognosis, all their medical conditions, making sure they're going to take care of those and the medications when they leave. We talk about their prior histories of self-care practices, if they're still able to do those when they leave the hospital. What kind of family and social supports do they have, of course, and what are some of the resources that we can provide for our patients when they're able to either go home, all right? Remember, stress can interfere with a patient's recall and responses to your questions. And of course, hospitalization is a high stressor for them. So be sure they're comfortable and relaxed and they're warm. Give them time to respond to you, and don't forget those short teaching sessions is also important. All right. Wow, so much to know about acute care, but we could use this information on almost any setting. It could be long-term care facility, but this is just some basic information that's important. Now we're going to clinical, all right? We are going to clinical. And here is our first clinical. Now, this one is going to be a little bit harder if you don't have your, well, maybe you'll be able to, because you should be able to see this slide at all times. However, see if you can remember some of these things. So who wants to start reading this? Kendrick, could you read this clinical practice for us?
An 80-year-old woman was admitted to the hospital following a motor vehicle crash. Her injuries include a left fractured hip, left compound wrist fracture, and multiple contusions and lacerations. The nurse notes that preoperative buck traction has been applied to the client's left leg with 2 weights of 5 pounds each. Her left lower arm has an external fixator to manage the open wound while the fracture heals.
Okay, very good. Thank you. So, Heather, can you tell us in just a couple of sentences or words, what do you see with this patient? What do you see? Because we're going to need this information when we go to the next slide. Summarize.
Okay.
Yeah.
So
Summarize it.
there was a accident and quite a good bit of trauma
Okay.
and extraction. Yeah.
You're doing great. You're doing great. What else is
Okay.
going on with this patient? What does the nurse's note say?
I'm sorry, what?
The nurse's note. What does the nurse's note say? Or what does the nurse note, I should say, not note.
Oh, okay.
Sorry, I didn't mean to
Just
confuse you.
that buck extraction has been applied to the left
Mhm.
leg, and then her left arm has an external fixator.
Okay.
So yeah.
All right. So she's got a lot of injuries, right? So what is her injuries?
The fractured hip on the left side, the fractured wrist on the left side, and bruises, and then just some lacerations.
Okay. So class, in your mind, you should see a vision of this woman. Everybody see her? Can you see her? Mm-hmm. If you can see this woman in your mind, now we're going to the next slide. So for each nursing action, you need to specify whether the action would be indicated, which means appropriate or necessary, contraindicated, it could be harmful, or non-essential, makes no difference, or is not necessary for the client's care at this time. So let's read through those, and you can mark them on your paper or however you want to in your head, whatever you'd like to. I want you to give you a couple of minutes to read through each one and determine is, for instance, the first one, remove traction weights when turning the client. Is it contraindicated? Is it indicated or non-essential? So I'll let you do that, take you a few minutes, and then we're going to talk about it. All right, I'll give you another 30 seconds. Are we pretty much ready to do some of these things?
Yes.
Okay. All right. So let's just start. Ashley, Tawari, your nursing action is the first one. So if you will read that and tell us what you think should happen with this particular one. Ashley, are you there? All right, no Ashley, fine. Kiyomi. Okay, no Kiyomi. Amber?
This is
I
Kiyomi.
don't
I'm here.
think
Okay, okay, we'll come back to you, Kiyomi. Let's go ahead and let Kayla take this one. I mean, Amber, I'm sorry, Amber.
You don't remove the traction weight, so I think it's contraindicated.
Okay. All right, keep that in mind, y'all. Mark your sheet there. All right, and so we'll go back to Kiyomi. Kiyomi, can you tell us about the second one here?
Oh, sorry, I had to unmute. Assess pin sites of external fixator for signs and symptoms of infection. Indicated.
Okay. All right, good. Next one, let's see. Taylor, proper. Let's do the third one.
The third one is take the client's temperature every hour. And I was a little iffy on this one because I don't know if it's every hour, but I know you want to keep track of the client's temperature to make sure they don't have systemic signs of infection. So I put non-essential. I would say not every hour, but maybe every 4 hours.
Okay, so non-essential, correct?
Yes.
Good. All right, Yvonne.
Check the cast to ensure it's not too tight. I think it's indicated.
Okay, indicated. That's what she put. All right, let's go to the next one. Emily.
Manage the client's pain. I would say that's indicated.
All right. And Uma.
I'm sorry, which one is it? I was thinking about the cat. She doesn't have a cast.
Okay, we're going to get back to that. I haven't given the
Okay.
answers yet. Okay, so what? It's the next to the last one. Assist the client.
Assist the client when she is ambulating with her walker. That's contraindicated because she's in the box traction and she's preoperative.
All right, that's what her answer is. And how about Mai? Mai, you get the last one.
Check all traction ropes and nuts every shift for intactness. I would say it's indicated.
All right. Did everybody get this correct? These are your answers. Did you get 100? So definitely not going to remove the tractions. You were absolutely correct. You're going to always assess your pin sites. And you were absolutely correct. We're not going to take it every hour. So it's not essential. So read it as it's written. It says every hour. So you were correct in saying not essential. If it had said every 4 hours, you would have selected that. Okay. All right. Check the cast. And I think Uma, you brought up a good point. Why do we not check the cast on Buck's traction?
She doesn't have one.
Correct. She does not have it, and an external fixator is not a cast either. So there's no cast to even mess with. Okay, managing the client's pain. Obviously, it's indicated. An analgesia. Remember, we talked a little bit about that. It's better to start low, and so we're going to try an analgesic for that. Insisting the client ambulation. Obviously, she can't